So, welcome to the third and last part of this presentation on focused ultrasound, where we'll discuss the rapid spread of this technique, some thoughts on the number of patients that may be treated, the market, costs, prices, organization and such, all questions of potential relevance if you are yourself considering to invest in a focused ultrasound. In order to understand the success of FUS, it is not enough to look at the effects and complications, but we need to apply a wider perspective. I am a surgeon because I enjoy brain surgery. However, even though it might be difficult to understand, most patients do not actually want to have brain surgery. The success of FUS is to a large extent driven by the patient's preferences, and patients are not as fond of cutting and drilling as surgeons. However, the success of FUS cannot be understood only based on the patients, but we need to look also at the manufacturer and the profession, and how these are affecting each other and the patients. And the manufacturer has been very successful in marketing their product, both to the medical profession but also to the patients. And it is here of interest to compare the FUS to other lesioning tools. A radiofrequency lesioning system is so cheap that there is almost no profit to be made, and if there is no profit, then there will be no sponsored studies, no courses or such. Further, it is an open procedure, but might not appeal to the patients. However, the gamma knife is an incisionless technique, and according to the review seen here, the gamma knife is similar in efficacy to the FUS, but with a trend towards a higher efficacy, as well as more complications with FUS. My own knowledge is very limited here, but I have understood that there are quite divergent opinions on the gamma knife thalamotomy. It has some potential advantages such as sedation or sleep surgery, it is pain-free, the patient can keep the hair, one can reach also more lateral brain targets, but also evident disadvantages such as a delayed response. Anyhow, I find it interesting that even if the gamma knife has been around far longer than the FUS, the interest for functional procedures has been limited. There are probably several reasons for this. And one of the most important is simply that the gamma knife has a non-functional profile. And it is normally not a functional neurosurgeon who buys one with a functional procedure in mind. If we return to DBS, then one advantage is that there is no real investment. The cost for the implants is reimbursed more or less immediately. With FUS, you are making a large investment, and the reimbursement from each patient will help you to pay off this debt. This means that you actively need to find patients to treat to manage this debt. Further, since the cost for the FUS itself constitutes a high proportion of the total cost for the procedure, this means that your profit will increase for each treated patient. Normally, a hospital will have a rather restricted uptake area. However, the market is too small for it to be economically profitable with the FUS at each department performing DBS. Thus, a department investing in a FUS will extend its uptake area also over neighboring departments without a FUS. And it is important to realize that this might also be the case regarding patients who are not optimal for FUS, and there are even departments without access to DBS that offers FUS, and not all machines are run by neurosurgeons, but some by neurologists or even by radiologists. However, we should not exaggerate this, and we need to remember that FUS is mainly limited to unilateral thalamotomies for essential tremor and to some patients with Parkinsonian tremor. And it is likely that the positive attention FUS has received will lead to a growing interest also for DBS, not least from patients not suitable for FUS due to low SDR or other causes. Further, it seems unlikely that FUS will compete in any serious manner with DBS concerning bilateral surgery or procedures in the GPI or STN. Anyhow, I believe that we need to take all these factors into account when we try to interpret the staggering change in perspective that has occurred regarding lesions among many neurosurgeons and especially neurologists, at least among those that have a FUS. I have already mentioned that the focus regarding complications here has shifted from the target area to the way towards the target. Further, in publications with what would probably some years ago have been considered as many side effects of a significant nature in DBS, the authors will now conclude that FUS thalamotomies are safe with few complications of a serious nature. Concerning the complication rate, they would previously have seen the glass as half empty, but now it is suddenly half full. Many of those now performing FUS thalamotomies would some years ago have claimed that microelectrode recording is indispensable in order to localize the optimal target in the thalamus, but now this is no longer necessary. The reversibility of DBS was highly praised and one of the main reasons to why people replaced radiofrequency thalamotomies with DBS, and some even went so far as to claim that lesioning the human brain when there was a reversible alternative was unethical. However, the reversibility is no longer an issue when it comes to FUS. There is perhaps nothing right or wrong here, but a change of perspective is interesting. Another important question is how many patients we will be able to treat. This is a difficult question and will vary with a number of factors. According to these figures here, we might assume that in a population of 10 million inhabitants, there should be about 111 to 385 patients per year with moderate to severe drug-refractory essential tremor that might be eligible for FUS. However, you need to take into account the reimbursement system and that some of your colleagues, for various reasons, might not be interested in referring patients to you. Further, many patients will have a too low SDR, others will have other contraindications, some are better candidates for bilateral DBS, and of the remaining patients, a substantial number will probably not want to have any invasive treatment at all. There are centers who are treating a large number of patients and have long queues. But there are about 160 FUS centers in the world, and on average, these will treat about 30 patients per year. This low number is partly due to some centers having just started, but others are simply struggling to find the patients. An increased awareness among patients and referring centers will probably increase the demand, but on the other hand, we are now tapping into a large pool of essential tremor patients who can't have or don't want DBS, and this pool has been assembled during several decades and patients are waiting in line for FUS, but at some point we will have emptied the pool. If we look at the Danish experience, then they had 2 machines, but one is now closed, presumably since they could not get any economy in it. Regarding the other, this has recently often been presented as an example of the large need for FUS, and it was presented to me as an example of how many patients I could expect. 69 patients per year in a population of 6 million since they started in June 2022 is impressive. But as we see here regarding the number of patients referred for consideration of FUS, which of course is not the same as the number of patients which will receive FUS, they had been accepting referrals for several years before they actually started. And the number of referrals actually peaked before they started using the machine. And there is now a dramatic reduction in the number of referrals as you see in the curve, and they interpret this as that they have emptied part of the pool of previously untreated patients, and it is not clear how much further the number of referrals might sink before the curve flattens out. How many patients you need to cover your costs will vary for each individual center, and especially on how much you will charge for each treatment. It was suggested to me that more than 40 patients per year would make the procedure profitable, but I believe that this was an optimistic estimate if one would like what I would deem to be a reasonable price for the procedure. The most southern region in Sweden made a detailed analysis and came to the conclusion that with one FUS machine in Sweden, well over 200 patients must be treated per year in order to reach a reasonable cost efficiency, which they demanded to be below 22,000 euros. However, as we have seen, it is highly unlikely that one would find 200 patients per year to treat in a country with only 10 million inhabitants. Thus, we must probably accept a higher cost per patient. So, how many patients you need depends on what you find to be a reasonable price. For USA, numbers of 80 to 100 have been mentioned, and I would guess that around 60 to 80 might be reasonable for Europe, but this is, as mentioned, dependent on how much you charge and on your costs. You also need to decide if you can have the cake for yourself or if you will have to share it. Let's say that your colleague in the next hospital buys one, and since he is successful, you do the same. If you are sharing the same cake, then probably neither of you will be successful. And if even more want to share the cake, then it will be no fun at all. And this has already happened in several places. The FUS is not like the gamma knife, and you can only use it for functional lesions. And if we assume that you do 3 a day and a total of 60 cases per year, then you can do all of them in January, or spread it out over 3 days per month. If you operate 3 patients on 1 day a week for 40 weeks per year, then you can do 120 procedures per year. Thus, most of the time the machine will just be standing there costing you a lot of money. So if you have the possibility, consider if you can create a collaboration with your neighboring hospitals around one machine to the benefit of all of you. The difference in perspectives regarding the gamma knife and the FUS is quite interesting. The gamma knife is a tool needing an engineer, and where one will have a hardware-centered organization focused on utilizing the hardware as efficient and much as possible. Around 700 procedures per year is probably quite optimal, and in Sweden Karolinska are doing 550. It is a more expensive machine than the FUS, but used in a more cost-effective manner. And in Sweden, a gamma knife thalamotomy will cost less than 1/3 of a FUS thalamotomy. The FUS is presented more as a tool for the individual engineer, resulting in a non-hardware-centered organization revolving instead around the user, and where the machine is used only at a fraction of its real capacity, which might not be very cost-effective. And in Sweden, a gamma knife thalamotomy will cost 7,200 euros, while a FUS thalamotomy will cost 25,500. No one would probably buy a gamma knife to do 40 or even 120 procedures, and this difference is in my view mostly based on a narrative. We have accepted that with FUS it is okay to make very few procedures at a high cost, while this is not acceptable with a gamma knife. When we are dealing with the DBS manufacturers, we are used to them approaching us clinicians for discussions on whether to buy their systems. However, with FUS it can be slightly different, and sometimes the hospital management rather than the clinician has been contacted directly and provided with information about the profitability of buying a FUS. And according to a couple of Spanish colleagues, this has been common in Spain and is a reason as to why a country of 48 million inhabitants now have 13 FUS machines. Actually, one Spanish colleague claims that there are 16 machines in Spain, but 3 have closed due to lack of patients, but I don't know if this is correct. Some consider it remarkable when the public healthcare in Gran Canaria invested in a FUS for the small population of the Canary Islands. But presumably, they were even more surprised when Tenerife now have decided to buy their own machine, so their inhabitants will not have to take the ferry to Gran Canaria. Some find the FUS to be expensive, but there is no such thing as a fair price in a capitalist system, but the price will be based on supply and demand. The price of a FUS varies a lot in the world, but is in Europe 2,500,000 euros. However, if you want to use the machine, you must also pay the service fee of 190,000 euros per year. If we assume that the FUS will last for 12 years, which is the time Insight Tech guarantees that spare parts will be available, then the service will amount to almost the same sum as the initial cost, or 2,280,000 euros. The high service fee is not because it needs a lot of service or expensive replacement parts. It is rather an added amount in the form of yearly installments. Thus, you will never really own your machine, and the real cost for the FUS would seem closer to 4,780,000 euros, depending on how much value you attribute to the real service. And of course, you also have to add the disposable treatment kit for each patient. This consists of a gel block for testing of the machine, 4 screws, and a silicone membrane for the water cooling. The cost for this is 3,500 and 4,250 for the new model with coils. Some savvy persons have actually been reusing the membranes. However, in order to hinder this, each membrane is now marked with a unique code which you have to enter into the machine, and it will not work if you have used the same code previously. The price for a FUS phallomotomy varies, and I have only knowledge of the price at a few places, where it varies between 25,500 and 38,000 euros for a unilateral procedure, and supposedly the double for a bilateral procedure, but I don't know how representative these numbers might be. And if we look at other procedures in Sweden, then the gamma knife is the cheapest procedure, followed by the radiofrequency lesion. At my department, a unilateral FUS is cheaper than unilateral DBS, but a bilateral FUS would be more expensive than bilateral DBS. If you are interested in buying a FUS, then you also need to be aware of the ethical guidelines of Insightec in order to avoid any misunderstandings. I was negotiating with them about buying a machine, the X-Plate Neuro, but then a colleague from Queen Square told me that Insightec was introducing a new system with a head coil with better imaging. So before signing any contract, I reached out to them to make sure that we were getting the newest system. However, they did not want to discuss this on email but suggested a Zoom meeting. At the Zoom meeting on April 17th, they assured me that there was no new system on the market. There was ongoing research, but there was no new system with better imaging and no new system with head coils, and would not be under the foreseeable future. And they reassured me that I was getting the latest system on the market. I was happy with this information, and we bought the X-Plate Neuro. However, at this meeting on the 17th April, they chose not to inform me that just the day before our Zoom meeting, they had made a press release informing that the X-Plate Prime, the next generation of focused ultrasound, was now CE marked and available on the European market, or that they had been advertising this new system since several months in the USA. A system that, in their words, had undergone a complete transformation compared with the old system, and among other improvements included an optimization of the imaging and an upgraded 3 Tesla head coil for improved imaging. I did of course become somewhat confused when I later learned about this. And when I asked them, they told me that for ethical reasons they were forbidden to tell me about the new system, since this could have been perceived as advertisement of a product under development. I pointed out that they had advertised the system for months in the USA, and that they had made a press release already the day before our meeting informing that the new system was CE marked and was available on the European market, and they had put this information on their web page. They then informed me that they had been explicitly ordered by the management to lie to me, not in order to dump the last of the old systems on me, but simply to follow their ethical guidelines. Further, they pointed out that since none of my colleagues in Europe had a new model, the old model was actually the newest model, at least on the European market, so I was actually getting the newest model. Thus, if you are considering to buy a FUS, then it is important that you are aware of the company's very strict ethical guidelines. And with that, I end this short overview. Thank you for your attention, and please remember that you will find more than 250 lectures on similar topics at the Stereotactic Academy at stereotactic.org. Thank you.